right? Different combinations. That's it. You can feel that there's less structure when we compare both types. Right? Now, the last type are adhesive molecules, chondronectin in cartilage, osteonectin in bone, fibronectin in the fibrous connective tissues. If you know the difference between these two and know in general what the ground substance is, right, that would be very important. And let's talk about the connective tissue to know. We have areolar connective tissue. And again, with all of these, we usually have seen it in the microscope, right? So areolar connective tissue, loose packing, found in most organs and tissues. They're important for support and nourishment of the structure, right? Also known as a stroma. We see it in our integument, right? The integumentary system is a combination of your skin, epidermis, dermis, and the deeper fatty tissue underneath it, right? So the fatty tissue underneath is called the hypodermis. We're gonna see lots of loose areolar connective tissue in the hypodermis region of our integument. You'll also see it, right, in the dermis as well. Right, often seen in association with other connective tissue. So when we see this areolar connective tissue in the dermis, we're gonna see that it's associated with dense, irregular connective tissue. When we see the areolar connective tissue in the hypodermis, it's gonna be associated with adipose tissue. So they're found in different combinations. Next, fat. Fat's a connective tissue, adipose tissue, right? So in terms of fat, there's, just understand there's two of them. White or yellow fat, right here, large distribution. This is our storage form of fat. So when you overeat, right, and people wonder, well, I don't eat fat, how come I'm getting fat, right? Well, what happens is if you eat a lot of sugars gets converted to the fat. You don't need to eat a lot of fat for that to happen, right? The sugars get converted to fat. So what happens? The more fat that we produce, the more we add into those adipose cells. The adipose cells then start to enlarge. So it's not like when you get fat that, it's not like you gain more cells. You just have the same number of cells. You're just adding more fat to each one. And each of the adipose cells then enlarge. Now that's white, yellow fat. Brown fat is actually protective, right? We see brown fat near the axilla, near the neck. Remember, in the neck, you don't have any bones in the neck region protecting your carotid artery, your jugular vein. There's nothing there to protect. All we have are just a little bit of brown fat to protect that area. We'll see the kidneys also has a lot of brown fat protecting it, right? You have the last few ribs there, but that's it. All right, so fat, so far it's fat and areolar, both type of loose connective tissue. The next category is going to be reticular tissue. And with reticular tissue, know where we find it, the lymphatic vessels and hemopoietic tissue, the bone marrow, right? Even the spleen and liver, right? Now what happens? Contains, and really in our microscope, as we stained it, it became that really bright blue color, if you remember, really bright blue, and that is the reticular tissue itself, right? They're found between spaces, between cells, which are the white blood cells. They're coated with glycoprotein, helps with maturation of your white blood cells. That's one important thing it does do, is help with the maturation of our white blood cells. Right? So know that where they're found and know that they help with maturation of white blood cells. Next, are more, before we had loose connective tissue, now it's not so loose, it's dense. So dense regular connective tissue, dense irregular connective tissue. Now, with dense regular connective tissue, there's two categories. One, dense regular collagenous. The second one, right here, dense regular, elastic connective tissue. So I'll go from one to the other first. Dense regular collagenous has lots of collagen fibers, all stacked together, all in the same plane or axis right here, right? It makes it really strong in that same kind of orientation. So if you think about your biceps, right? Your bicep muscle, main purpose is just to move your forearm, right? So what happens? The biceps, all of the fibers of your biceps are facing up and down, all right, longitudinally. That's what it's supposed to do. So it makes sense that the tendon that you feel here also are made out of dense, regular, collagenous connective tissue. All of those collagen fibers are also facing up and down. So then when you are able to kind of grab something, right, you don't rip the tendon from the muscle itself or rip the tendon from the bone. So it's very rare that you actually see somebody, even if you go to the gym, every now and then you'll see people that are trying to do something a little too heavy, right? Kids, high schoolers do this a lot, right? And they put their back into it, right? And they can do one time. And what they're doing then is putting a lot of stress on that bicep. At the same time, they very seldom rip the bicep. They don't injure themselves, right? Well, why not? It's because even though they're doing a weight that's way above them, right? Because of the strength of the dense regular collagenous connective tissue, it doesn't rupture. Now, if they try to do it in a different way, it might. So have you ever seen World's Strongest Man? You do see injuries when they rupture the bicep, but it's not when they're kind of holding something like this. Usually they're grabbing like one of those big Atlas stones, right? A huge stone, and trying to lift it up. So what happens then? Their elbows are out and they're squeezing it in. Now you have a different axis of stress, right? That weight they can normally handle if their arms are underneath them. But now their elbows are out and they're grabbing like this. It's not as strong because you're moving that axis point a little bit. That's when they rupture the tendons, right? And when they rupture it, it kind of shrinks back, and you can see the muscle actually move towards the shoulder, which is crazy. So these tendons and ligaments, they follow, right? The actual organization of these fibers follow the movement of the muscle they're connected to. So the bicep moves up and down. It makes sense that the fibers found in the tendons also are oriented in the same direction, making it incredibly strong in one direction. Ligaments also contains dense, regular, collagenous connective tissue. Ligaments connect bone to bone. Anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament. They prevent unwanted movements between your femur and your tibia, right? Well, tendons connect muscle to bone. That's a big difference between those two. In both those regions where we have tendons and ligaments, right? In ligaments, you're gonna have dense, regular collagenous connective tissue, real strong in one direction. So your ACL, imagine that my left fist is your tibia. My right fist is your femur, right? Your ACL prevents unwanted movement of your tibia forward, right? So it's usually pretty strong going that way. Most people don't rupture their knee when they're just moving forward, right? How do they hurt their knee in a non-traumatic way? Meaning somebody isn't tackling them. If they're tackling them, then their knee kind of hyperextends. You can imagine how it's easier to rupture then, right? But if you ever see what happened to Jordy Nelson for the Packers, right? What happened with them? What happened with them is when they cut in one direction, right? Well, the ACL is only supposed to go in that forward and back direction. Now you put a sideways slant on it. It's not as strong Because of that, there's a greater ease at rupturing because all the fibers are going only front and back. When you have a different movement, sideways, right, it's easier to rupture. Yes?
Is it a way to make like your ACL stronger?
Now, usually by the time people get to that point, right, you might have parts of the actual tendon and the ligament in that area that are already slightly torn, right? You can't really strengthen it. The only way we can strengthen it is with repair. Going in there, but you actually have to go in there and repair it. So once you rupture it, you can't even repair it at that point. You have to go in there and replace it. So usually we do like either a cadaver replacement or we take a tendon from your, very strong muscles like your quadriceps or your hamstring, and we'll take a tendon, stretch it out a little bit, and that becomes a new ligament. Kind of weird, but it should work, right? It's got the same arrangement of these collagenous connective tissue. Now, next, dense, regular, elastic. Before it's dense, regular, collagenous. Dense, regular, elastic connective tissue is going to have elastic and collagenous connective tissue. Now, where do we see it? In the vocal cords. The elastic connective tissue in the vocal cords allows you to move the vocal cords, to tighten it. As you tighten the vocal cords, when air hits it, that tightened vocal cord shakes faster, giving you the higher pitch soprano sound. When you loosen it, the vibration when air hits it, right, causes your vocal cords, remember, they're loose now, to vibrate slower, allowing us to hear the deeper bass sounds, right? Now, that's a function of the elastic component, allowing us to change pitch. The collagenous component is for strength. So not only can you sing with a lot of power, right, at a high-pitched voice, you can sing with a lot of power in a low-pitched voice. The power is due to the collagenous portion right here. So then you have strength when you're trying to belt out a tune, right? You need both. Because if somebody sings, they're a really good singer, but you can only hear them when you're 2 inches away, right? Kind of defeats the purpose. You want to be able to hear somebody, and that person needs to have a really strong voice when you're a singer, right? Well, what protects the vocal cords at that point, when you're belting it out, are the dense, regular collagen fibers, also found there. So when we say there's dense, regular, elastic, understand it's got elastic tissue, but it still has collagen tissue as well, right? It's not just all elastic tissue, in other words. Next, dense, irregular, collagenous. And we saw this underneath the skin. Dense, irregular, collagenous, you have thick collagen fibers, but the collagen fibers, notice there's no one direction that they're kind of pointing here. Here you can see that there is a one direction for all of the collagen fibers. They're parallel to each other. Here, some of them are going left and right. Some are going up and down. There's a randomness to it. There's an irregularity to it. What happens? It allows us to have strength in multiple directions. So we find it deep to the skin in the dermis. So you can pick up the dermis. You can move the dermis left and right. You can even push in on your skin. And when you let go, it comes back, right? So it's strong in multiple directions, but not as strong in any one direction. The last type of these kind of connective tissue here are dense, irregular, elastic. Again, when we use the word elastic connective tissue, understand that yes, it's got elastic connective tissue, but it also has collagen still, right? That could be a true and false question, right? So with dense, irregular, elastic connective tissue, we find it in the large arteries, like your aorta. Your aorta is huge, right? But the aorta is receiving blood from the left ventricle of the heart. As blood goes from the left ventricle to the aorta, you have a lot of blood moving into the aorta with a lot of pressure. So that blood that the aorta is receiving, there's a lot of it, there's a large volume, and the blood as it goes through is very pressurized. So what we need to do is have the aorta be able to withstand that stretch as that blood comes in under high pressure, under high volume, right? We need it to stretch accordingly. That's why we have so many elastic connective tissues here. So then when the aorta receives the blood, it can receive it, it can stretch, right? Now as it stretches, you don't just want it to stretch in one direction. You want it to stretch in a 360-degree direction. That's why there's an irregular pattern to it, right? Irregular, multiple directions. So it's strong in multiple directions, yet stretchable in multiple directions. Cartilage. Right? Cartilage is considered a type of supporting connective tissue. Right? It's got a composed of chondrocytes. So these are the chondrocytes over here. We know they're chondrocytes because they're surrounded by this pink colored matrix right here. Right? Now, with cartilage, it's got a firm consistency. It's got lots of proteoglycans and hyaluronic acid complex together. If it was just hyaluronic acid, remember, it'd be like a gel. But now we add proteoglycans and hyaluronic acid together. It traps the water, right? And makes it more solid in nature. Right? Now there's another important one. All cartilage is avascular, and it has very poor nerve and blood vessel supply. Because of this, right, they either heal very, very, very slowly, or it doesn't heal at all. Right? We're gonna see your articular cartilage in your knee, in your ankles, in your hip, they don't heal. They don't regrow. So when you rip it and you tore it, I don't know if you guys, I have my son's friend plays football for the Badgers, right? And there was a player that was only a freshman, right? So his first year, well, he damaged his knee so many times in the last year and a half. And each time he damaged it in such a way that he damaged the cartilage, right? So by the end of his freshman year in college, he had to retire from football. He was bone on bone, the knee. When you're bone on bone, it's just a matter of time until the pain is so bad that you need like a knee replacement, right? So what happens is once you damage that cartilage, it's really hard to fix it. Now, I always use that example, right? How many times have you guys heard of a basketball player having something called, right? Having certain kind of, surgeries, right? One main surgery you hear them having is called microfracture surgery. Microfracture surgery, I have never heard of somebody saying, yep, he had a successful microfracture surgery. Usually when they have an ACL tear and you do a repair, it was successful, right? They have any surgery, it's successful. But with microfracture surgery, you guys understand, they're not trying to fix the fractures. They're actually causing the fractures. That's a microfracture surgery. They're using little micro drills into the knee so then they can hopefully cause little miniature fractures, which will then stimulate more cartilage growth, right? It almost always fails because it's so hard to stimulate cartilage growth again. Why? No blood supply. How are you going to heal when you can't bring any nutrients in? You can't, right? Perichondrium contains dense, irregular connective tissue surrounding the cartilage. In areas where we do have a perichondrium, we can have regrowth, but it's very few and far in between are those areas that have perichondrium. Right, so all the cartilage we'll talk about will not be usually repairable, will not heal by itself, right? So let's talk about this one, Highland cartilage. Highland cartilage is found at the ends of all our long bones. It's found in the movable joints of our long bones. So when we talk about the Highland